You've been referred for an electrical study of your heart with a view to an ablation because of a condition called SVT, or supraventricular tachycardia. In order to understand what this is, you have to understand how the normal heart beats. The heart is made of 4 chambers, 1, 2, 3, 4. The heart beats because electricity moves around the heart. It normally starts at the top of the heart over here, this being the top right of the heart, the left of the picture but the right of the heart. This electricity comes down to a structure in the middle of the heart over here, before coming down to the bottom chambers of the heart, like this. Now, from time to time, you've been experiencing palpitations or dizziness, and the understanding is that this may be related to a condition called SVT, or supraventricular tachycardia. These top chambers are called atria, these bottom chambers are called ventricles. Supraventricular means above the ventricles, i.e. in these top chambers here, and tachycardia means fast heartbeat. So you're experiencing an electrical problem in the heart originating in these top chambers of the heart. Now, there are several different types of these electrical problems in the top chambers, and they are all originating from short circuits that can occur. The most common short circuit is seen over here. It is a small short circuit, more commonly known as AVNRT, or atrioventricular nodal reentry tachycardia. This short circuit lives quite close to this structure called the gatekeeper of the heart. It is through a procedure called an electrical study that your doctors can diagnose whether you have this condition or any other condition, and then at the same time treat it for you by a procedure called an ablation. There is another common short circuit of the heart which actually connects the top and the bottom chambers. Here, some patients can be born with an extra gatekeeper between the top and the bottom chambers. So not only does electricity come down the heart through this structure here, but it also can come in this way as well. And this can result in another type of short circuit, which looks like this. And this is called AVRT, rotating round like this. It is another type of SVT. Now, in order to determine what type of SVT you have, your doctors will perform an electrical study of the heart. How does this happen? Well, in order to get access to your heart, they will try to get to your heart through your groins, where there are blood vessels, both arteries and veins, on both the right and the left side. Your doctors will decide, most likely to get access from either one or both sides of your groin, and usually involves the veins. Using some local anesthetic and some small tubes, they will be able to get access to your heart through these veins, which run from your groin up towards your heart as such. And through them, they will pass a catheter up the vein, which allows us to register and recognize the electrical signals within your heart. Most of these electrical studies within the heart involve having 4 of these electrical catheters situated within the heart. And on that basis, we tend to get access from both the right-sided veins and the left-sided veins as well. Your doctors will discuss quite frequently with the team surrounding them about the different electrical behaviours within the heart. In order to then try to establish a diagnosis, they will perform various manoeuvres using these catheters, and they will aim for you to get into the tachycardia that you've experienced. Once you are in it, they will be able to confirm the diagnosis that they may have been suspecting, and then on the same sitting they will proceed to an ablation procedure. An ablation is a fancy word for burning. It involves identifying where exactly the short circuit you have and destroying a small piece of tissue which is critical to the short circuit, either here or here, to prevent these short circuits from sustaining. In doing so, we can offer a curative treatment approach with 95% certainty of long-term freedom from the SVT that you have been experiencing. This would allow you to stop all the medications that you may have been taking for this condition. So what should you expect? Before the procedure, your hospital will advise you to not have any food from midnight before your procedure and not have anything to drink early in the morning. This sometimes can be delayed depending on the time of your procedure. If you are on blood thinning medicines, we will usually ask you to stop these for several days, sometimes up to 5 days leading up to the procedure. This will be at the discretion of your physician and your local hospital policy. What is critical is that if you are on any medicine to try to suppress these short circuits, you will be asked to stop these medicines for at least 5 days. During the procedure, you will be awake for this. You should not expect to feel any pain. The local anesthesia will cause a degree of discomfort at the groin, but that will go numb once the anesthetic has kicked in. The ablation itself usually goes without significant discomfort, but if of course there is any, we can offer you sedation and analgesia as required. We do not want to do this procedure under general anesthetic for fear that the anesthesia itself may suppress the short circuits from demonstrating themselves under the influence of anesthesia. This may preclude effective diagnosis. The procedure itself will happen in the electrical laboratories in the cardiac catheterization labs. You will be greeted by the doctor, the consultant, the physiologist, the nursing staff and a radiographer. You'll be asked to lie on a table which will allow the doctors to see inside your heart using x-rays and to determine the electrical signals within the heart from the catheters positioned within the heart itself. The procedure itself usually lasts between an hour to an hour and a half. Once the procedure is done, there is usually a 20 to 30 minute waiting period whilst the doctors make certain that what they have done has been effective. Be aware that during the procedure, they will aim to get you into the arrhythmia that you have been experiencing. This allows us to have confirmation of what the short circuit is that you are experiencing. At the end of the procedure, sometimes the doctor may give medicines to try to stress the heart in order to determine how effective their treatment has been. Sometimes these medicines can be unpleasant, but the effect lasts for a short period of time, and the net gain is that they can be more confident that we will have successfully treated the arrhythmic problem. Sometimes during the procedure, your heart may not go into the arrhythmia like we would have wished. In order to bring it up to its surface, the doctors may give you other additional medicines. They mimic adrenaline in order to get your arrhythmia more sustained. Once the procedure has been completed, you will return to the day ward where you will be met and cared for by the nursing staff for several hours. Once they are satisfied, you will be discharged home on the same day. Finally, we do this procedure very frequently and it's generally very safe. There are risks, they're small but they do exist and you must be aware of them. We quote around a 2% risk of bleeding complication down at the groin. That includes, at worst, a blood transfusion or needing surgery to repair any groin complication. Up inside the heart, the risk of complication is 1% or less. That includes causing a tear in the wall of the heart, causing blood to leak around the heart into a sac. If that were to happen, that could make you feel acutely unwell and would require us to pass a drain to take that blood away, or rarely heart surgery. The risk of this is around 0.5%. An important complication specifically related to some of these procedures, in particular for this type of SVT, is inadvertent damage to the natural gatekeeper of the heart. This structure is pivotal to allow the top and the bottom chambers to communicate, and if this is inadvertently destroyed, you would need to have an artificial pacemaker fitted permanently. The risk of this is up to 1%. The risk of life-threatening complication, like a heart attack, stroke, or death, is around 1 in 1,000. You would expect to have at least one follow-up appointment by your electrical heart doctor in outpatient clinic following the procedure. Sometimes we recommend giving an aspirin, 300 milligrams on the eve of the procedure and 75 milligrams for 6 weeks thereafter. You should expect to have, in a successful procedure, for all your medicines related to this condition to be stopped. For any further advice or information about this procedure, please look online at the Arrhythmia Alliance.